So good afternoon and welcome to the post-lunch session. I thank at the outset the organizers, especially the duo who has so wonderfully organized this conference, and thanks for the opportunity. My topic is on GLP-1, why GLP-1 receptor agonist is the best choice for glycemic control versus SGLT2 inhibitors and GLP-1 receptor plus GIP, the talk that we just heard of. My talk will run into three aspects: introduction, how does GLP-1 receptor score over the other, and how does the both scores over the GLP-1 receptor. How does GLP-1 receptor scores over the both combination. So we all know there is an inadequate glycemic control in India. 77 million living with diabetes, 77% of people with diabetes have poor glycemic control, and only about 8.6% have mean HbA1c level which is less than 7%. So there is a definite need for a better control. So people with type 2 diabetes are at increased risk of CV complications with unstable angina, myocardial infarction, heart failure, stroke, and even peripheral arterial disease. So coming to how does GLP-1 receptor scores over the SGLT2 inhibitor, my next speaker will speak to us wisely about that. And also, how does GLP-1 receptor will be the next one. So glycemic efficacy of oral semaglutide, I'll be talking to you about oral semaglutide first, and then I'll come to the injectable semaglutide. So we all know about the Pioneer 2 study, which was done with the GLP-1 receptor agonist with head-to-head comparison with empagliflozin. So oral semaglutide 14 mg provided a superior reduction in HbA1c compared with the empagliflozin 25 mg at week 26 and 52. And 7 out of 10 patients achieving the targets of HbA1c less than 7% with oral semaglutide. So weight loss mechanisms, when you look at that, SGLT2 inhibitor and GLP-1 receptor agonist. SGLT2 inhibitor works only by glucouresis, that is calorie loss due to increased renal glucose excretion, and GLP-1 receptor agonist has many mechanisms whereby it reduces the weight, that is by inhibition of gastric emptying, decreased calorie ingestion through central nervous system, and reduction of acid secretion. Superior glycemic control by oral semaglutide is compared with empagliflozin. 63% of oral semaglutide offers 63% greater HbA1c reduction than the empagliflozin 25 mg. We most commonly use 10 mg in our practice. So this was compared with 25 mg, and even there 63% was achieved by semaglutide. Now, as I said, 7 by 10 patients achieved HbA1c less than 7, and 4 times patient achieved HbA1c target with oral semaglutide versus 25 mg of empagliflozin. So when you look at the systemic inflammation, there was Pioneer 2 study which clearly showed that there was a reduction of 37% of inflammation with oral semaglutide. And when you look at compare the ease of use, choice between oral OD dose, when you look at the GLP-1 receptor agonists, of course it was very easy, and SGLT2 not very easy because it has to be taken in the morning, it has to be taken with water, it has to be told to the patient that all the side effects have to be informed, and it is almost like an informed consent that is to be taken with every patient. eGFR monitoring not required with GLP-1 receptor agonist. Ketonuria and ketonemia monitoring is not required, and antihypertensive treatment monitoring usually not required with GLP-1 receptor agonists. So coming to the risk and tolerability, risk of genitourinary infections, very low risk, or if at all no risk with GLP-1 receptor agonists, and here SGLT2 inhibitors, we need to use it with caution. So all other risk of amputation, we know about the canagliflozin, and risk of volume depletion, risk of fractures, all of these are very much low with GLP-1 receptor. The only thing is pancreatitis and maybe gallbladder stones patients and cancer of thyroid history needs to be looked into before we start the patients on GLP-1 receptors, and GI adverse events have to be also cautioned. So what about the drug safety communications? These are all the communications that are there in the handouts to the patients. Fourniers, gangrene, amputation risk, acute kidney injury, urinary tract infections causing serious kidney and blood infections, bone fractures, and diabetic ketoacidosis. These are all the warning signs, black box warnings are given by the FDA requirement. So these are not there for GLP-1 receptor. And the risk of fractures, GLP-1 receptor is almost nil, but maybe there with the, very low risk, not to be really mentioned. When you come to SGLT2 inhibitors, induced increased bone risk fracture, although it is hardly seen in our country, but if a patient has already amputations in the past, you need to be cautious about putting them on the SGLT2 inhibitors. So this was a comparative safety review between GLP-1 receptor agonists and SGLT2 inhibitors. You have cardiovascular events, which is both are protective, blood pressure, both are protective, volume depletion, SGLT2, you need to be cautious in patients who are dehydrated. Fractures, you need to be cautious. Heart rate, the GLP-1 receptor may increase the heart rate, so you need to be a little cautious about patients who have tachycardia. Heart failure, of course, SGLT2 scores over the GLP-1 receptor, and pancreatic disease, GLP-1 is safe, but SGLT2 is neutral. And genitourinary infections, of course, cautious. Amputation the amputations, GLP-1 is neutral, and SGLT2 one needs to be cautious. So key takeaway for GLP-1 and SGLT2 inhibitors, rising incidence of diabetes in turn increases the risk of CVD. The mortality, morbidity due to CVD is considerably high in postmenopausal women. GLP-1 receptor and SGLT2 inhibitors are two classes of drugs recommended to be used in diabetic patients with CVD risk. GLP-1 receptor shows significantly better HbA1c reduction as compared to SGLT2 inhibitors, and the weight reduction benefit of GLP-1 receptor agonists is significant and sustained, and SGLT2 inhibitors increase the significant risk in fracture incidences, increase probability of urinary tract and genitourinary tract infection, which are an important adverse effect seen in females particularly. So coming to development of ASCVD, we all know that early endothelial dysfunction is there while patient gets, at the onset of diabetes, and it increases with monocyte recruitment and foam cell formation, development of fatty streaks, and atherosclerotic plaque formation. So how can we reduce this is the question, and when we write a drug, that is what we need to look into. We need to look into the efficacy, body weight, and hypoglycemic effect. Now, SGLT2, both have very good effect on this, but potential side effects of the SGLT2 inhibitors need to be thought of before you put the patient, and whereas a GLP-1 receptor, you need not think about those things. Now, exceptional CV benefits of GLP-1 receptor agonists is to be understood. This is a given particularly for disease of pipes, which is benefits of GLP-1 receptor agonists, are predominantly on ASCVD pathway, that is pipes. All the guidelines now advocate the usage of GLP-1 receptor right at the top of the onset of treatment for diabetes. And the SGLT2 inhibitors are particularly given for patients with heart failure or a pump patients. Patients with type 2 diabetes are definitely at high risk of intrinsic myocardial disease, particularly women with microvascular cardiomyopathy, hypertrophy, and fibrosis, stiffness, heart failure. So benefits of these two have to be understood and thought of. So GLP-1 receptor agonists provide multiple benefits in patients with type 2 diabetes, reduction in HbA1c, fasting post-lunch, minimal hypoglycemia, weight reduction, CV benefits, tolerable side effects profile, and approved for wide variety of patients. So this is an umbrella to protect ourselves from the reign of various complications of diabetes. So therapies to manage type 2 diabetes, we have these GLP-1 receptor versus SGLT2 inhibitors. We all know about ominous octet. Now, the GLP-1 receptors act at all these in fact, 6 areas, whereas SGLT2 inhibitors, they function with decreased glucose uptake and increased glucose reabsorption. So the inhibition of increased glucose reabsorption. So there are only 2 areas where the SGLT2 function. So the glycemic or reduction of HbA1c effect of SGLT2 is slightly less as compared to GLP-1 receptor agonists. CV mechanisms, we all know. Now this is all GLP-1 receptor, reduction in inflammation, glucose increase in uptake, reduction in ischemic injury, improves the liver function, improves the heart rate, reduction in inflammation, whereas SGLT2 inhibitors, you have already heard about all this. So this improves mainly the heart failure. Now GLP-1 receptor, not SGLT2 inhibitor, should be preferred antidiabetic for ischemic stroke prevention in patients with diabetes. Finding the right class with existing evidence, SGLT2 inhibitors and GLP-1 receptors, you have all these benefits which are higher in terms of efficacy of HbA1c and significant HbA1c and weight reduction with oral semaglutide has been already established. And in the SOUL study, the MACE by 14% adults with type 2 diabetes was established, CVD and CKD. Now, this has been already described in detail by my previous speaker. So, in brief, GIP and GLP-1 are 2 main incretin hormones, and the only complementary effect of GLP-1 makes it better in terms of weight reduction, but all the other effects are mainly because of the GLP-1 receptor agonists. So injectable ones, we all know that is available now. But one important thing that I would like to say is diet and exercise guideline should be given to all the patients who are taking GLP-1 receptor and SGLT2 inhibitors as well. Maintain muscle mass, energize and balance, avoid GLP-1 side effects of constipation, nausea, heartburn. Liquid for hydration is to be maintained. So semaglutide is the only GLP-1 receptor agonist with positive health outcomes in CKD patients and with type 2 diabetes. It addresses all 3 components of the ADA EAST consensus report and definitely needs to be advised if patient can tolerate the price as well as the drug. Thank you.